Please welcome from the University of Kentucky and many other places. He's a traveling kind of guy. Please welcome Dr. Chauhan.
Good morning, everyone. My name is Chauhan, and I am Assistant Professor of Medicine at University of Kentucky Markey Cancer Center. First of all, I'd like to thank all of you guys for showing up in such a big numbers. I think it's a fantastic meeting, and this is the third time I had this opportunity to talk to neuroendocrine tumor patients at an NCAN meeting. And I'm profoundly thankful for Bob and Marianne for giving me this wonderful, wonderful opportunity. Washington, D.C. is also among my most favorite cities in the States. This was the first city I visited in the United States back in 2008. In fact, the first city I visited outside India at that time. And at that time, I was a medical student. I gave a talk on prolactin in GI cancers. So in the last 15 years, I've moved away from prolactin, and I'm going to be talking about serotonin. All right. These are my disclosures. I've gotten some grants from NIH, BMS, Clovis, regarding some phase 2 clinical trials, and some intramural grants from university and Markey Cancer Center. So a little bit of history about serotonin. Serotonin was first discovered back in 1935 by an Italian scientist named Ersparma. He didn't call it serotonin, but he found this substance in the cells which are lining your gut called enterochromaffin cells. And he named this compound as entramine. Later, about 17 years ahead, Page and colleagues found this chemical and named it serotonin, and its property was that it was a vasoactive substance, caused vasoconstriction and these autonomic disturbances. But it was in 1952 that somebody figured out that both these compounds were one and the same thing. So truly, it was back in 1935 that's when entramine was really serotonin. So kind of neat little history of serotonin. So some brief primer about what is serotonin, how is it made, where is it made, and why is it bothersome? Why do we have to lower it? So serotonin comes from an amino acid which we derive from our diet, food, tryptophan. And tryptophan is converted into serotonin inside our body in basically two major steps. The first step is conversion of tryptophan into 5-hydroxytryptophan, and then the next step would convert it into 5-hydroxytryptamine, which is serotonin. The three most prevalent sites for serotonin in the body are the gut, the platelets, and our brain, CNS. The serotonin which is made in the body doesn't really cross the blood-brain barrier, doesn't go to the brain. And the serotonin made in brain has a very vital role. It is a neurotransmitter. Neurotransmitters are the chemicals which help two neurons or the brain cells to communicate with each other. So it's a really important chemical, helps regulate mood. You've heard about SSRIs. These are the antidepressants. So you're trying to raise those neurotransmitters in the brain. However, the serotonin which is made in gut has a completely different role. So these tiny little cells, the blue and yellow cells which are lining the gut membrane, are called enterochromaffin cells, and these are the cells which are making most of these serotonin in the gut. And what is it doing there? it's helping maintain the gut function, the motility, the secretion, because our gut's always producing intestinal juices, help with digestion, etc. And also the nerve fibers which innervate the gut muscles, it helps to communicate so that they can do peristalsis, which is a fancy term for the gut motility. So guts always has a rhythm like heartbeat. Not as fast, but it kind of has this flowing rhythm which pushes all the food from one end to the other, right? So that's the normal function of serotonin or this chemical in the gut. However, we're not concerned about normal today. We're going to talk pathology, right? So serotonin is also made by neuroendocrine tumor cells. And it's actually a vicious cycle because neuroendocrine tumor cells make serotonin, and in turn that serotonin acts as a fuel, in very simple words, to promote further growth of neuroendocrine tumor cells. Okay, so it's a vicious circle which kind of keeps feeding, right? So we need to break this. And we know this because in our labs, we have done studies where we've grown these neuroendocrine tumor cells from lung, from pancreas, and there is a correlation between high serotonin and the tumor growth in terms of the cell growth and proliferation. So serotonin overproduction in a neuroendocrine tumor cell is a step-by-step process. As mentioned before, we eat food, food has proteins, protein breaks down into amino acid. One of the key amino acids we are focused on is tryptophan. Tryptophan gets absorbed in the cell, and there is a really, really important enzyme here, tryptophan hydroxylase. Okay, that is the rate limiting step converting tryptophan into the first intermediary compound 5-HTP, which then converts into serotonin, which is 5-HT. Okay, once serotonin is made, it is stored in these small globules or vesicles, and it just remains there in the cell till somebody has aged cheese or drinks a glass of wine, and then they release it, and then you get flushing. So the cells release serotonin into the blood, which kind of breaks down and then forms 5-HIAA. That's why 5-HIAA in urine is a very good marker to also indirectly measure serotonin, because it's coming from breakdown of serotonin. Why do we need to know about serotonin? Because elevated serotonin can cause two major issues in our neuroendocrine tumor patients. One is that can give rise to what's called carcinoid syndrome, and secondly, it can definitely promote tumor growth. So let's talk about the first scenario first. What is carcinoid syndrome? So carcinoid syndrome is a symptom complex of various symptoms. Most commonly, it's flushing and diarrhea. You all are aware of it. By far, that's the most commonest symptom complex of carcinoid syndrome, and it's very, very quality of life limiting. We've all known people and seen patients with diarrhea, which makes patients stay at home, avoid work, avoid public places. Flushing affects their mood and quality of life. So this is a real issue. However, today I'll be talking more about life-threatening symptoms or conditions because of high serotonin, which is carcinoid heart disease, mesenteric fibrosis, and pulmonary artery hypertension. We have a dedicated talk about carcinoid heart disease, so I won't be going into too much details about this. But what is carcinoid heart disease? So carcinoid heart disease is a symptom complex of anything wrong with heart because of carcinoid syndrome. And what can go wrong with the heart when your serotonin is up? Primarily, your valves can get destroyed. Serotonin causes injury to the endothelium or the inner lining of heart and the valves, causes plaque deposition in the heart. Valves, it's literally chews it up. The valves get destroyed. And especially it's the right side of the heart. And if the right side of the heart, which is called tricuspid valve, gets destroyed, then there's a lot of reflux or backflow of the blood, which puts a lot of pressure on the right ventricle, which causes pulmonary artery hypertension down the road. So people develop right-sided heart failure to begin with, which can eventually also progress into the left-sided heart failure. It is a very important complication and often irreversible. So the onus is on to us to monitor for development of carcinoid heart disease and try to prevent it, because once it's happened, the mortality and morbidity is quite high. This is a very important slide. So on the left-hand side, on the right-hand side, there is the statistics which shows all-cause mortality in neuroendocrine tumor patient. So if your serotonin or 5-HIAA level is normal, in this particular study, the median survival was found to be 1 or 2 months. But in a subgroup where there was 10-fold increase in serotonin levels, the survival was almost half. And this is not because of cardiac disease, this is all-cause mortality, okay? So having high serotonin, meaning high 5-HIAA, is bad. Patients do bad. So that's why I want you guys to be cognizant of this fact. And that's why we need to really manage your serotonin, bring it down. And one of the reasons why patients do bad when they have elevated serotonin is because of development of carcinoid heart disease. So the screen on left side, the bar graph shows the incidence of carcinoid heart disease increases as the level of serotonin increases in the blood. So especially if 5-HIAA is over 1,000 or 900, it's a very, very high chance of developing carcinoid heart disease. How do we treat carcinoid heart disease? Again, I won't delve too much into detail. The key is to lower the serotonin down and replace the faulty valve. The valve replacement needs intricate management with the cardiologist and thoracic surgeon. And to lower the serotonin down, we need an aggressive oncologist. And the tools we have currently are somatostatin analogs, liver embolization, cytoreductive surgeries. But more recently, we have a new kid in block, Zermello, which is not indicated for carcinoid heart disease, but can be potentially looked into it in future. We have an anecdotal case where we had an exceptional response. A patient developed florid heart failure and was placed on high-dose Zermello, and today she is walking and talking and doing fantastic. So this is something definitely worth looking forward to. Moving forward, another really quality of life limiting and life-threatening complication from elevated serotonin is mesenteric fibrosis. So this is a CAT scan of a patient with mesenteric fibrosis, and this is the scar tissue you see, the fibrosed mesentery. So mesentery is a tissue which basically holds your gut to the abdominal cavity. And if there's persistent elevation of serotonin for many months and years, it can cause scar tissue formation there. And this can then in turn lead to obstruction, which are very difficult to treat and difficult to operate surgically and manage surgically. They can also develop retroperitoneal fibrosis, which can cause obstruction to the kidneys. In fact, I was actually on call last week, and one of my patients, unfortunately, has developed the ureteric obstruction because of that. And these are very difficult cases to manage, you know. So the key is to kind of hope that these don't develop, and the best thing we can do is to be aggressive to lower their serotonin to begin with, okay? All right. So, and then lastly, there's pulmonary artery hypertension, which can also happen because of elevated serotonin. And the mechanism of that is either because of the right-sided heart failure, or also it can directly cause hyperplasia of the musculature and the valve thickening of the pulmonic valve and leading to pulmonary artery hypertension that way. Secondly, elevated serotonin can also cause tumors to grow, right? So it's not just the carcinoid syndrome, but also in terms of pure tumor progression, it's elevated serotonin. It's very critical for us to lower it. This graph shows two groups of patients, one with elevated serotonin in blue and one with low serotonin or 5-HIA in green. The patient clearly in green are doing a lot better. They're living a lot longer. These are survival curves. So we know elevated 5-HIA and serotonin are poor predictor for overall survival, right? So we need to really strive to bring these serotonin and 5-HIA in control. It's very important. How do we do it? Because this is a biomarker which we need to control, it gives us an opportunity to treat it as a therapeutic target, right? And there are primarily two ways we can lower serotonin. One way is by decreasing the secretion of the serotonin from the neuroendocrine tumor cells. And the other way is to block the production of it altogether. Let's talk about the first way, which is decreasing the secretion of serotonin through neuroendocrine tumor cells. How do we do that? So back in 1986, I was 1 year old when this data came out. So Dr. Larry Coles, he's a legendary doctor. In fact, during one of my first NCAN meetings, and that's the reason, Marion, I don't miss these meetings, because it's my first NCAN presentation 2 years back. I was still a trainee, and I had an opportunity to share podium with Dr. Coles, probably one of his last public presentations, and he is such a phenomenal guy. And today I had another opportunity. We have another legend among us, Dr. Ed Bolin. And that's why I do not miss these meetings, because, you know, it's history making. So back in 1986, Dr. Coles published this landmark study in New England Journal of Medicine, which is our premier medical journal. And he showed that somatostatin analog can help with carcinoid symptoms, carcinoid syndrome symptoms, and also lower 5-HIAA. Later on, our pharmaceutical industries and partners, they developed two compounds. One's called sandostatin, other one's called lanreotide. These are long-acting forms of these short-acting somatostatin analogs, right? The first trial was done called PROMATE trial. It was done between 2002 and reported 2008 in Journal of Clinical Oncology. And it evaluated sandostatin, octreotide LAR, and it showed that that octreotide LAR slowed the tumor growth. The patient who got octreotide LAR had progression-free survival, median progression-free survival of 14 months as compared to, I think, 6 months in the control arm, which was placebo. Subsequently, Clarinet trial was done with lanreotide. It's a similar premise. It was also a phase 3 randomized placebo-controlled trial, which randomized patients between lanreotide and placebo, about 100 patients each in those arms. And at the time of the trial was reported, the median progression-free survival was not even attained in the treatment arm. So that was that superior, whereas it was about 18 months in the placebo arm. I think in 2017, Dr. Volin presented the Clarinet extension data, and now we know the median PFS in the treatment arm is actually 38 months. So imagine 38 months versus 14 months. That's a very profound benefit of adding somatostatin analog, long-acting release, in tumor growth prevention. And based on these findings, both these agents are approved, and both NANET's guidelines and NCCN guidelines recommend these agents to be used as a frontline treatment, systemic treatment agents. And I feel these are by far the agents of choice, or forms the backbone of the treatment of our neuroendocrine tumor patients, because they're relatively very safe toxicity profile, and they really work. Lastly, we have the new kid on the block called Zermelo. Fantastic drug. It's first in its class oral tryptophan hydroxylase inhibitor. So how does it work? Remember, earlier on I said there are two ways we can lower serotonin. One is by reducing its secretion. Second, by just killing the production of serotonin, or at least that's the thought process. So we'll be focusing on the second pathway to block that hormone, the enzyme which converts tryptophan into 5-HTP. That was the rate limiting step, remember, in serotonin production. So if we block that enzyme, we'll hopefully block the production of serotonin in neuroendocrine tumor cells. And to prove whether it works, a large phase 3 international clinical trial called TELESTAR trial was done. And as you can see, in TELESTAR trial, there were 3 treatment arms. One was high dose Zermelo, 500 milligrams TID. Another one was standard dose, 250 milligram TID. And third was placebo. The 5-HIAA levels were significantly dropped in the treatment arms, both high and standard dose. Placebo, as expected, we did not see a decline, right? So what does that mean? Of course, if we lower serotonin, we should see benefit in carcinoid syndrome symptoms, especially diarrhea. That was the key indication they were looking for, at least in this trial. So this trial was evaluating effect on diarrhea, carcinoid syndrome diarrhea, patients more than 4 stools a day, refractory to somatostatin analogs, right? And look at these curves, the stool output was statistically significantly lower as compared to control or placebo arm in both high and standard dose Zermelo. Based on these findings, FDA finally approved Zermelo for use. I think this is a great drug, usually very safe, and can be added to somatostatin analogs and other cytoreductive, targeted, or chemotherapeutic agents for control of carcinoid diarrhea. So I would like to conclude by saying serotonin overproduction is a driver of carcinoid syndrome. We all know that. Especially, it plays an important role in developing carcinoid heart disease, mesenteric fibrosis, retroperitoneal fibrosis, pulmonary artery hypertension. And lastly, serotonin is also responsible for tumor growth. And this is known, a well-known fact from the preclinical study and from the clinical trials. We know that by blocking or lowering serotonin, we do retard the tumor growth. So controlling serotonin exposure is important to improve quality of life and prognosis of patient with carcinoid syndrome. With that, I would like to thank. I would also like to welcome you guys, if you guys are ever in our backwood in Kentucky. If not for neuroendocrine tumor, we have lovely horse races and bourbon. Alrighty, I'll be happy to take any questions later.